Hey guys, with the recent uptick we've had recently in rattlesnake bites, Ben Cooper and myself have decided to give you just a quick little refresher on rattlesnake bite treatment and transport protocols. What we're going to talk about today is just going to be brief. We're going to cover Colorado rattlesnake bite statistics, an overview of the snake, what the symptomology of what you're going to find in a bite, our treatments, our transport considerations. We're going to cover our snake bite protocol, which is in your Boulder County protocols. And then Ben is going to have a short video at the end, just as a little refresher on how to create push dose epi again for everybody. So, in Colorado, since 2012, there have been over 500 rattlesnake bites. And really, what precipitated this training was we had 4 bites in Boulder County on 5/29 of 2020, 2 of which were run by Rocky Mountain Fire units. With these bites, approximately 15% are fatal if they're untreated. And even with treatment, 2% can be fatal. So it's important that we recognize these victims and provide them rapid treatment and transport. So here in Colorado, specifically the Front Range, we're lucky in that the only wild venomous snake in the region is the prairie rattlesnake. That's not to say we won't eventually encounter some exotic snake that was released by a handler. But when it comes to hiking on the trails and things like that, for the most part, this will be the only snake we come across that envenomates people. They tend to hide under rocks, although they do sun themselves out in the open to warm up. After all, they are cold-blooded. An interesting fact about them is about 25% of these are dry bites, meaning they don't actually inject venom. They're just, their teeth marks will be left behind. But it's important to know that you should still definitely treat those patients as rattlesnake bite victims and bring them to the hospital. Their venom is hemotoxic. The root word of that is hemo, meaning blood, so it's mainly going to affect your ability to clot. So what we'll come across sometimes is a misidentification, because also native to our area is the bull snake, which if you look at this slide, you can see prairie rattlesnake on the left, bull snake on the right. They look extremely similar. And oftentimes, as were the 2 bites that occurred this week for Rocky Mountain Fire, the snake struck without rattling. So we can't take the presence or absence of a rattle to determine whether it's a rattlesnake bite or not. So it's important to know that people may have actually been bitten by a bull snake, and that from a distance you might not be able to always identify correctly what kind of snake it is. So also extremely important to note is when it comes to rattlesnakes, size doesn't matter. In fact, the smaller may be worse. If you look at that picture on the left, that's actually a baby rattlesnake next to a lighter to give you really a good size comparison. The smaller snakes do carry venom. And in fact, their bites may be worse because unlike adults, that can essentially titrate their venom and how much they inject into an individual. The baby snakes, when they bite, they dump all of their venom into you. So their snake bites may be far worse. So the takeaway point from that is just because it's a small snake doesn't mean the patient's going to be any better off. In fact, they may be much, much worse.
So your symptoms will likely be easily sort of distinguishable into 2 different categories. Your localized non-envenomation symptoms and your systemic envenomation systems. Your localized non-envenomation symptoms are really honestly not that big of a deal, right? You're going to have some pain around the site, might have some swelling, some bruising, perhaps a little bit of numbness, some redness, things like that. The takeaway is non-life-threatening and uncomfortable. We're not really going to do much for those patients except get them out and still take them to the hospital for evaluation in case there was some amount of envenomation. Your systemic symptoms are going to be far worse, and those are the ones that are really affecting your ABCs. So because it's a hemotoxic venom, you can deal with this downstream sequelae of symptoms from hemotoxicity, right? So it's not just going to affect the blood, because once the blood starts going all wonky, you're going to start affecting all other organ systems, and you eventually end up in a multi-system organ dysfunction. So the things that we are likely to see are an altered mentation, hypotension, which we'll aggressively treat, and then there's that sort of subjective finding of a funny metallic taste in their mouth, although that's not present in all bites.
So the takeaway from this slide, and the reason we included it, is to show you that a couple of things. First off is, if you look at those bite marks, it might not always be that impressive. In fact, the extremely critical snake bite victim we had on 529 had basically a similar size envenomation mark. So it might not be that visually impressive. However, they can have grossly systemic issues. The second takeaway I want everybody to look at there is make sure to mark the area of erythema or redness with a pen and mark it with a time, because that's extremely important for hospitals and the toxicologist to track that envenomation throughout the body. So those two things right there just might be small bite marks, and to mark that redness area when you make contact.
The last thing we want to do with our treatment is make something worse, either by something we actively do or forget to do. That's why our treatment starts with pretty simple stuff. You're going to remove clothing, anything that's going to constrict the limb, so jewelry, watches, anything like that. It's best to immobilize or splint the body part, whether it's below the heart or above the heart or at the same level of the heart. Really, that's going to depend on what your evacuation plan is. And there's not a ton of evidence that points in any one sort of direction in that. So whatever gets your patient out the quickest to antivenom treatment, which is the thing they actually need, is really the preference there. It's important to, as Brad was saying, mark the margins of redness and swelling around the bite, and then keep that in mind and sort of, mark it with time so you can pass that on to the ED. As someone is completing those top three items, you should actively be looking at whether the patient is also having a concurrent allergic reaction to the snake venom. In that case, they might have signs of, say, their throat closing, or might have signs of angioedema. And so in that case, you're just going to treat it per our standard allergic reaction treatment. Epinephrine IM, some Benadryl, etc. Rattlesnake bite victims often present with hypotension, right? Because you're dealing with a toxin that causes lots of effects on the blood, right? It makes your membranes leaky, it can cause vasodilation, and so you can end up with a hypotensive patient. So aggressively treat this. IV fluids first, treat with vasopressors next. Our choice for a vasopressor is going to be epinephrine, and our preferred method for giving epinephrine in most instances is going to be push dose epi. Rattlesnake bites are incredibly painful, so manage the pain. We have two drugs that do a pretty darn good job of this, fentanyl and ketamine. Fentanyl would be probably my first choice. It's an excellent med for this, especially even if the patient is hypotensive. But if the patient is persistently hypotensive, not responding to treatment, fentanyl might not be the best idea because you could potentially worsen their hypotension. So dropping in a little bit of ketamine might be a nice plan. Limit the exertion for the patient. So patient really shouldn't be hiking out. We don't want to stress their body out anymore. We don't want to worsen the outcome. And so these are litter carryouts. We don't want them to exert any more than they need. The most important thing is to get them out of there. And all of the treatments that we've done prior to this are leading up to transporting the patient to the right place that actually has antivenom stocked. So I wouldn't say that you wouldn't want to take the time to manage these, manage the ABCs, absolutely, manage their pain, absolutely, but don't delay unnecessarily on scene necessary transport to get them to a facility with antivenom. Be sure to call the hospital to make sure that, one, they have antivenom in stock, and two, they can actually take a snakebite victim. The other day, Brad was mentioning that BCH I think they got 4 snakebite victims, or 3, at one time, and so they were real close to basically saying, no, we can't take any more snakebite victims. You're going to have to go to another hospital. And then last is the things not to do, and those are basically the old wives' tales of, the treatments that you might find in an old Boy Scout manual, right? You use a suction kit to suck the venom out. You use ice packs or tourniquets to limit the venom spread. And the truth is none of that stuff works, and some of it can actually make your patient worse. So don't do any of that stuff. Get your patient to a hospital with CroFab. That's basically this slide summed up. Most Front Range hospitals stock it because rattlesnakes are all over the Front Range. The next thing is to consider how you're going to get them there. And we use flight often in the Front Range, but if we actually, I think, took a look at our calls and said, how often did air medical save a significant amount of time that actually had an effect on patient outcome, I think the answer might surprise a lot of people. So my personal thought here is most of the time ground ambulance is going to be sufficient and potentially a better option. Air medical could be a good option if you're in a more remote area of our district, say way up Flagstaff Road, or if you were in a remote area and the air medical service could bring you in CroFab. In that case, you would need to specifically name request it, and that's going to increase the time for air medical to get there. Other than that, ground ambulance is really going to be your best option.
So this is a copy of our Boulder County snake bite protocol. There's a lot to go over here, most of which has been covered by us, Ben and myself, during this last talk. So just pull this out, open up your app, pull out your book, and just look at it real quick, just to give a quick review and to refresh your memory on what we should be doing for these patients.
So CroFab is the trade name for the antivenom that is used for rattlesnakes. It is incredibly expensive, anywhere from $6,000 to $10,000 per vial. And when your loading dose is 4 vials, well, you can do the math on that one. But it's also incredibly effective, and I believe the last data I saw was something like 98% effective. So this is like the definitive treatment. There's really nothing else to give. But it is not a benign drug. It does have some amount of complications like many other meds out there. And the most common thing that you might see is an allergic reaction to the CroFab itself. So it doesn't mean you're going to stop CroFab treatment. It just means you're going to treat the allergic reaction while you're continuing the CroFab treatment. So you might help a flight crew administer CroFab if they bring it into your scene. So that's kind of why I'm covering this, because it's definitely not in our protocols and we don't carry it. The next little bit of our training is going to be instructions on how to make push dose epinephrine. At one point in the video, I just want to mention I do say that if you drop a little too much or a little too little, it's no big deal. Please don't take that as me saying that dosing doesn't matter or the exact amount that you give isn't a big deal. It certainly is. What I'm trying to get across is with the types of syringes that we use, it's actually really difficult to accurately get exactly 1.0 milliliters drawn up into your flush. So when you're watching that, just kind of consider that. We have a wide range of dosing that we can give for push dose, so that also gives us kind of a pretty good amount of flexibility in our dosing from 5 to 20 micrograms. So just consider that when you're watching the video.
This is going to be a demonstration on how to make push dose epinephrine, which is basically just 1 to 100,000 concentration of epinephrine. So you'll need the following equipment. You'll need either a 21 gauge green IM needle, or you'll need a twin pack, and you'll use the red blunt tip catheter from the twin pack. You'll need a 10 cc saline flush, and you'll need 1 preload of cardiac epi, or the 1 to 10,000 dose of epinephrine. So this box is a little janky, so we're gonna rip it open. You don't need this part. that can go away. You take your 10 cc flush, and it's fairly important to try and be as accurate as possible here, because as you see with a 10 cc flush, the demarcations are to the half cc, and so your precision is actually not going to be very good here. So do your best to get as much air bubbles out and be as accurate with your reading as possible. So what I'm going to do is I'm going to get rid of 1 milliliter of normal saline, and I'm going to keep 9 cc's or 9 milliliters of saline here. So as you can see, I got about 9 cc's now. Okay, so from here, I'm going to draw 1 cc of this epinephrine into the syringe. If you happen to draw a little bit more or just a touch less, it's not going to be a deal breaker, and you'll still be able to use it. Okay, so this is just a vial of medicine, right? Just a weird type of vial. So you're gonna pierce the vial of epinephrine, and then you're gonna draw up 1 cc. This is where don't worry about the measurements on the epi. You should be looking at the measurements on the saline flush. And you'll see it's already starting to draw simply because of back pressure. Like I started at 9 and it already drawed back to like 9.5. So I'll draw back to just over 10. And that's about where I want it right there. There's no air bubbles in there. And I'm good to go. So now I have 10 milliliters total. 1 milliliter of it is 1 to 10,000 epi. So I've just diluted it by a factor of 10. I now have 1 to 100,000 epinephrine. If you think about the dose, we started with 1 milligram in 10 mLs. I just took 0.1 milligrams or 1 ml and put it into 10 mLs. So now I have 0.1 milligrams in 10 mLs, which is 100 micrograms in 10 mLs. So that's 10 micrograms per ml, and that happens to be my individual dosing of push dose epi. So I'm just going to give 1 ml at a time every 2 to 3 minutes to keep their pressure above, or to keep their pressure in like the 80 to 90 range. Really important though, you have to mix this up. So before I start giving this, I'm actually going to draw up a little bit of air so that this can be mixed and all that epinephrine can evenly distribute to those 10 cc's, and that's good there. If I didn't do that, you're not going to have an even distribution of epinephrine in your syringe. At this point, this looks just like a normal 10 cc flush. So what we got to do is we got to label it now. So using a medication added tag, you're going to label it with just these two things: the name of the drug and the concentration that is in your syringe. So I put 100 mics of epi into a 10 ml syringe of normal saline. That's all I need. I don't need anything else. When you're labeling it, please don't label where you occlude or block the unit measures. We need to actually keep those visible so we can see what our doses are. So best to label vertical. And now we have our finished product.
All right, so thanks to Ben for letting me record him, give us that quick review of push dose epi. And now conclusions. The big thing is rapid transport. Don't delay scene times. Treat these like we would a severe trauma patient, where we kind of load them up and get out of there. Be prepared to treat shock. The lesson learned from our call on the Fowler Trail was we were unprepared to treat shock. We didn't have an adequate dosing of epi. And then to make sure you call ahead for antivenin. Like we said, BCH was at their limit for snakebite patients that day. So had we called with another, they'd have told us to divert to another Front Range hospital, most likely Good Samaritan. If you guys have any questions on any of this, feel free to reach out to Chief Johnson, Chief Peavy, Medic Ben Cooper, or myself. And thanks for listening, guys.